रिकॉर्डिंग ऑन कर लीजिए. हाँ,
हाँ.
हो गया.
So, good morning. Welcome to IIP Delhi Cardiology e-classes. I request Dr. Pankaj Garg sir to say a few words.
So, good morning, everybody. Good morning, all the delegates. This is a forefront of pediatrics teaching program of IIP Delhi, in which we have been conducting master classes. In last few years, we have done it in the field of neonatology, cardiology, neonatology, hematology, endocrinology. Recently, we finished rheumatology last week, and that's now is the turn of pediatric cardiology. And for pediatric cardiology, I'm extremely thankful to Dr. NEERAJ Aggarwal, Dr. Mridul Agarwal, and Dr. J. Relan, who are the pillars of pediatric cardiology at Sir Gangaram Hospital. They have taken a lot of pains in making a great program, and this is going to be a 12-session program every Sunday, 9 o'clock. And I'm sure this will be great learning for all of us, all the office with pediatricians, students, and people in periphery who have to train themselves, upgrade their knowledge in all the fields, including pediatric cardiology. So I request Dr. Neeraj Agarwal to introduce himself as well as other coordinators of this course and then start the program. So over to Dr. Neeraj Agarwal.
So thank you IIP Delhi for this very beautiful initiative, because what I realize in our colleges also we are lacking in pediatric cardiology training. We have not seen many pediatric cardiac patients. We have not seen neonatal cardiac patients. So this was the need of the hour. So this was in context with IIP Delhi. We were talking for a long time that how do you train people. But after COVID, we got this idea that this can be done gradually. So we thought that let's do this program. I have started. We thought with Dr. Pankaj sir and IIP Delhi team that let's make a good program where private practitioners can be helped. So let us start with cyanotic basis of disease and how do you manage them in day-to-day practice, in the OPD practice, in the ICU practice. That was the aim of this program. And with this understanding, we have two program coordinators. That Dr. Jayaralan is available today. He is again a pediatric cardiologist in Gangaram, joined us 3 years back. He's an alumni of DM Pediatric Cardio from AIMS, an excellent person. He's soon going to start his own unit in somewhere in Faridabad. So he's an excellent person. And then Dr. Mridul is there. He passed his pediatric cardiology long time back with me and joined Gangaram in 2013. So 12-hour session with me. Dr. Mridul is not there today, but in next subsequent classes you will find him also. Then we have chairpersons. We have two chairpersons today. Respected Dr. Shivanand sir. I told he is a very, very good pediatrician in Goa, and he's a highly accredited person. People ask him for focus training when they have confusion in the abdomen, when they confusion, even radiologists ask him sometimes that what do you feel about this radiological finding. So he's very good actually. I have seen his videos, I have seen his understanding of CSDs. Sometimes I feel he's very good in neonatology cardiology. So I welcome him as a chairperson. I'm honored to have him as a chairperson, sir. Dr. Naveen sir, he has been a pediatrician in Karnal for long years. He has been a EB member of Haryana now, but I know him since like 2008 when I used to go to Karnal. I met him there in Karnal. He's an excellent person. He has wide knowledge of pediatrics and pediatric cardiology. Lot of people know him for gestures, like how do you do the meetings, how do you train people. He has great understanding actually. He has a great understanding of how to conduct a program, how to conduct people to push them to a super specialty. Dr. Naveen sir, welcome to our today's session. We are highly obliged, sir.
Thank you so much.
Thank you, sir. I will hand over to Dr. Pankaj sir again for if anything left from my side, sir.
I think Dr. Shamina is not here, so I take this opportunity on behalf of Dr. Shamina because we have another program today. He must have gone to Lee Meridian. So Dr. Shamina is the backbone of IIP Delhi along with Dr. Ajay Gupta, who is our scientific coordinator for all these master classes. And we have Dr. Dinesh Goyal and Dr. Nomita Gupta. So all of us together are able to do something in the field of pediatrics training and pediatric cardiology in particular. So I request Dr. Shivanand Ghosh to say a few words about this initiative of IIP Delhi and about today's session, and then Dr. Naveen to introduce Dr. Neeraj. Over to Dr. Shivanand, sir.
Good morning, everyone. First of all, I feel privileged an honor to be invited on this forum, and I fully appreciate wholeheartedly the initiative by Delhi IIP. It is a wonderful initiative which other IIPs should follow, and it is going to be a backbone of learning for a newly starting pediatrician as well as those who are in pediatrics, because cardiology is the field where we get stuck up, and we have a perception that it is only a echo diagnosis and we don't have stratified approach. So I am very grateful and thankful to Delhi IP for starting this initiative, and it is going to go a long way in especially training the younger budding pediatricians, and it is going to be a sort of a revision for the established pediatricians also. So I am very grateful to the Delhi IP, and especially a person like NEERAJ Aggarwal, who has been established cardiology department in a prestigious institute like Gangaram for last 14 years. Such an experienced person will be delivering a lecture today, and I'm looking forward to his lecture. Thank you so much for inviting me, and I'm looking forward for a fruitful scientific session.
Thank you, sir. Dr. Naveen, sir, few words from you, sir, for this initiative.
Thank you, Dr. Neeraj. It's a great initiative where I can see the national, in fact, international level speakers are there. Even my professor, Dr. Anita Saxena, is there. Dr. Neeraj has been heading the Department of Pediatric Cardiology at Gangaram, prestigious Gangaram Hospital. And personally, I have known him since 15 years, and he's an excellent person. Point to the point, he talks to the patient in absolute simple words, and this eco diagnosis has never been questioned in the city of Karnal, at least I know. You have Dr. Radhakrishnan, Dr. Munish Tomar, and other national faculties for the course, and I wish everyone best of luck. I hope the students learn a lot from you and take away good feelings and good vibes from this course. Dr. Pankaj, Dr. Ajay Gupta, and Dr. Sham Meena are behind this course. Obviously, they will leave no stone unturned to make it a super successful course. Best wishes. Thank you so much. Thank you.
Ajay, sir, can we start something?
So yeah, please start. We welcome Dr. Mridul Aggarwal, and please start the presentation, sir.
Thank you, sir. Thank you. Participant can put their question in the chat box. They would be answered in between as we
Yes.
put the questions.
In the chat box or question answer box.
Yeah. I will make this.
Sir, please make it full.
Yeah, I'm just doing it, sir.
Yeah.
It should be okay now.
Yes, sir.
Thank you. Thank you, sir. So, when I talk about management of CHD, as sir said, everyone wants to see the echo. But let us see, when the patient comes to you in your OPD or in your IPD, how do you think of CHD patient? And can I start a management? Can I give some drug beyond digoxin? Beyond digoxin, because I think digoxin is a commonly used drug in the IPD and OPD, which may not be true in all cases. So can we start the drugs before starting echo? This art is I learned this art in AIMS in 2005 when echo was not being done routinely and all emphasis was on X-ray and clinical parameters. So when we suspect a patient of heart disease, my first question is, do I have a patient with heart disease? Then if I say, no, this looks like a heart disease, my second question comes in mind is whether I'm dealing with cyanotic or acyanotic heart disease. Then if I have decided these two parts, then I say further two definitions. Whether I have a high flow pulmonary blood flow or low pulmonary blood flow. And then can I define RV type of dominance or LV type of dominance? This is also important. As the lecture progresses, we'll discuss this part also, the importance of this part. But if you can profile these three parts, which are easy actually, you can start management. Now, to answer a question whether I have a heart disease, this criteria was established long time back. It's called NADA's criteria. For DNB students, those who are in pediatrics, this is question asked also sometimes. So what are the NADA's criteria? How do you identify a patient with heart disease? And the NADA's criteria have defined the features in two parts, major and minor. In a major group, the features of, if you have systolic murmur more than grade 3, if you have diastolic murmur, if you have central cyanosis, or if you have congestive heart failure. Out of these 4 factors have been given major criteria, because systolic murmur more than grade 3 is rarely physiological. It has to be pathological. Similarly, diastolic murmur is always a pathological murmur. Similarly, central cyanosis and CHF, that's why they are in the major criteria. Now, in a minor criteria, if you have systolic murmur less than grade 3, you have abnormal second heart sound, then they are in the minor criteria. And if you have abnormal BP, X-ray or ECG, then they come into the minor criteria. So this comes to the point that when you have a heart disease patient, you have to look for cyanosis, you have to look for BP, ECG and X-ray and murmur. So most of the times, if you have identified these features, if you have one major or two minor criteria, you can say high suspicion of heart disease. Now, so if my child has a heart disease, my next question is, how do I divide this patient into cyanotic or acyanotic heart? Now, remember, especially in the newborns or in older children, the important part is central cyanosis. Now, if you have palm which are blue, your soles are blue, that is peripheral cyanosis, and that cannot be defined as a criteria for CSD. And we all know they are basically because thermoregulation, poor thermoregulation or cold temperatures. So we're talking about central cyanosis, which should be seen on lips, on tongue, on nail beds. That's how you define a central cyanosis. But objective criteria of central cyanosis would be a pulse oximeter, because eyes cannot pick up every cyanosis, like every desaturation cannot be picked up by eyes. Most of the times, if saturation is less than 85% in a child, eyes will pick up. But in that scenario also, if you have anemia, eyes may not pick up again, because deoxygenated hemoglobin is less in amount. So central cyanosis has to be demonstrated, and all such cases, if you want to decide cyanotic or acyanotic heart disease, the pulse oximeter has to be utilized. In all children, when you have a suspected CSD, either in OPD, IPD, or in neutral NICU, don't label a patient without doing a pulse oximeter. So it's very easy nowadays. Put a pulse oximeter, define cyanotic or acyanotic heart disease. Now, this is the classification which we should target. If I have defined my patient as a heart disease and I have a cyanotic or acyanotic group defined, then I have to define this spectrum into these two groups again. And if I can define my patient into these groups, I can start a medical therapy without echo also. So suppose if I talk about a patient has acyanotic, SATs are more than 93%, 94%, then I would like to define two groups. High pulmonary blood flow. This is pulmonary blood flow. This is normal pulmonary blood flow. High pulmonary blood flow is the most common lesion you see in your practice, in your ward rounds, in your OPD practice. Shunt lesion. Basically, they are shunt lesion, either in isolation or in combination. VSD, PDA, AV canal, AP window, or mixed lesion. They all are grouped into high pulmonary blood flow. Now, how do you assess high versus low flow? High versus low flow, I will describe in next slides. But remember a prototype of a disease. I will go with the VSD patient. We see the VSD patient routinely, and they come into the group of high pulmonary blood flow. Now, beyond, if you have a normal pulmonary blood flow, this comes to the group of obstructive lesions, AS, BS, coact. So, once I decide cyanotic or acyanotic heart disease, my next question would be pulmonary blood flow. Can I define a disease in high flow or low flow situation? Now, in acyanotic heart disease, most of the time you're talking about shunts in high flow, normal flow is obstructive lesion. Now, remember, all shunt lesion will not have high flow. So that means small shunts, suppose we have small VSD, small ASD, they would not have high pulmonary blood flow feature, because shunt is so small that pulmonary blood flow is balanced. They would be normal pulmonary blood flow. So few of the shunt lesions can come here if they are not significant shunts. Remember this part. This is a very important category to be defined once you want to start a management of a CHD patient. Similarly, cyanotic heart group, let us start with decreased pulmonary blood flow. Let us start with prototype. We all have seen these patients. In our residency days, in our private practice, we see this patient, which is TOF. And TOF is a VSD PS physiology. You know this four component TOF. There is VSD and PS. So pulmonary stenosis leads to low pulmonary blood flow. So in TOF patients and then TOF variants, they all are TOF variants. But remember, the important inherent feature of all these pulmonary blood flow situations is pulmonary stenosis. So any single ventricle patient, any complex heart disease, you look for whether I have a PS or not. If I have PS, I am grouping them into this group. That means low pulmonary blood flow. If cyanosis, so comes here. So if my child had saturation of 80%, and I say by my criteria that this is low pulmonary blood flow, then this group comes into picture. And then the other group would be high pulmonary blood flow. So all cyanotic heart lesions where you don't see PS, TJ with VSD, TAPVC, truncus without PS single ventricle, DRV with VSD, they all will come into the high pulmonary blood flow group. Now, some people define another group which is called mixing lesions. TG is a mixing lesion, basically, when you don't have enough shunts. So they're separate category. We'll define that separate category into duct-dependent lesions in future classes. But most of the times, you have to define cyanotic, acyanotic, and then flow, high flow or normal flow. Now, let's see how do I decide about pulmonary blood flow. This art of defining pulmonary blood flow, if you learn, you will learn the management of the CHD patients. So we have defined heart disease by NEERAJ criteria. Pulse oximetry has defined the cyanotic or acyanotic heart group. Now we come to this part. How do I decide whether I have a high or low or normal pulmonary blood flow? Now this is the clinical features which can help you to decide whether I am dealing with the high flow or low or normal flow. So let's see high pulmonary blood flow, and remember a patient of large VSD when we talk about high pulmonary blood. Like, do you have recurrent chest infections? Do you have failure to thrive? Do you have sweating? Do you have suck rest suck cycle? Do you have hyperactive precordium? That means when you see a chest visibly, you see the activity of the precordium, that is hyperactive precordium. Then you would have shunt murmur, and invariably large shunt would have a cardiomegaly. Now, if you see a large VSD patient, normally you will see this patient, recurrent chest infection, failure to thrive, sweating, and suck rest suck cycle. So large shunt patients who have high pulmonary blood flow would have these features most commonly. Now, if you compare this group to low or normal pulmonary blood flow, like remember a patient of TOF, which has a low pulmonary blood flow, cyanotic group, or if you have seen a patient of AS or PS, they will come to the low flow situation. See, they would not have recurrent chest infection because the pulmonary blood flow is not high, the lungs are not wet, you are not having recurrent chest infection. The TOF patients normally would not have recurrent chest infections unless there are some exceptions. Similarly, they would have good weight gain. So normally if you see AS patient, they are chubby patients. I have seen a lot of AS patients which are chubby. Rather than losing the weight, they are having high weight gain. Dyspnea on exertion, chest pain, that means adult symptoms. Adult heart disease patients, they would have symptom of dyspnea and chest pain. Because of obstructive lesions, they normally do have dyspnea and chest pain. Then neonatal shock I have kept because sometimes coarctation or ASPS can present with neonatal shock. But they will not have hyperactive precordium, they will have quiet precordium. You will not be able to identify any extra visible pulsations on the precordium when you're talking about low or normal pulmonary blood flow. Then mostly these lesions, ASPS, would have harsh murmurs, loud and harsh murmurs most of the times. And unless you are late, heart failure has happened, you will not have cardiomegaly. So TOF patients, normally they don't have cardiomegaly. AS patients, PS patients, they will not have a cardiomegaly on X-ray. So these are the features which you can think of when you're defining the high versus low pulmonary blood flow. So again, high flow means chest infection, failure to thrive, sweating, feeding. Here, no chest infection, good weight gain, dyspnea and chest pain are the features of low flow, and then quiet precordium and no cardiomegaly. Now remember again, small left right shunts and obstructive lesion, which are even moderate or severe, may be completely asymptomatic. So small left right shunts, we know they're asymptomatic, but for the new students, remember this part. Even severe obstructions may be totally asymptomatic. And that is the point you should not miss. They would have loud murmurs, severe obstructions, and they will be asymptomatic. Don't let them wait. Send them immediately for the further evaluation. Now, can I objectively assess the pulmonary blood flow? I want to see a objective criteria for pulmonary blood flow, and here comes the role of X-ray. And remember the X-ray of VSD, remember the X-ray of TOF to understand the QP. QP is the pulmonary flow. So VSD versus TOF X-rays, you remember in your mind when you talk about X-ray assessment of pulmonary blood flow. Now, this is a spectrum where you have a pulmonary blood flow. Jay, are you around? Dr. Jay?
Yes, sir. Yes, sir. Yes, sir.
Dr. Jay is around. Dr. Jay, what do you think about these two X-rays? Can you want to,
So,
do you want to elaborate on these two X-rays?
yeah. So whenever we see an X-ray, we see two things.
आपका
First
voice
thing that
बहुत
we
break हो रहा
see.
है. Dr. Jay, आपका your voice is broken.
Am I audible now, sir?
Slightly louder, but better. But can you be slightly louder?
Yeah. So when we see an X-ray, we see two things. We first see the heart side, and secondly, we see the vascularity in the lung. So normally, the pulmonary vascularity is visible up to 2/3 of the lung field. That is medial 2/3. So if it is extending more than 2/3, like we see in the first X-ray, it is extending in the peripheral 1/3 as well. So that is indicative of increased pulmonary blood flow. Now, if we see on the other side, the other X-ray, in this the vascularity is not even visible in the middle 1/3. So that is suggestive of slightly oligemic lung fields or decreased pulmonary blood flow.
So revising the things again, this X-ray is high flow, high QP, high pulmonary blood flow. This has a low pulmonary blood flow. Why? Because see, in simple language, this is white lung fields. This is black lung fields. So I know a lot of neurologists, they discuss white lung versus black lung. Similarly here, you see the white lungs here. As he says, the vascularity is going distally, where here I am not having any vascularity. So this has to be a low or normal QP, but this is high pulmonary blood flow. Now, if this high pulmonary blood flow and if it's acyanotic heart disease, ACHD, then high pulmonary blood flow will be shunt lesion. So I'm talking about shunts here, and I've ruled out obstructive lesions. It can't be ASPS and coart in this group. Whereas here, I'm talking about low pulmonary blood flow or normal pulmonary blood flow. So either this is, if it's ACHD, it is not a shunt lesion for sure, or it's a small shunt lesion. In a cyanotic heart group, if it's cyanotic child, low flow means TOF physiology spectrum. Either it's TOF or single ventricle, but with PS. So this group either is a normal QP or low QP, but not high QP. This is easily visible on X-ray. Now again, as Dr. Jay said, to define the objectively criteria of high pulmonary blood flow, either is cyanotic or acyanotic. Acyanotic heart disease like VSD, cyanotic heart disease like TAPVC. They are high QP X-rays, high pulmonary blood flow X-ray. They would have a cardiomegaly and vascularity. You know, lateral 1/3 is easily appreciable. So try to have a lateral 1/3 in the mind. And do you see the pulmonary flow? You see the vessels. See, these vessels are going till distally. And that's why you say this is high pulmonary blood flow age group. Again, one more criteria is most of the time, right lower pulmonary branch is easily visible on X-rays. This is the right lower lobe branch. And if it's prominent, you know this is dilated, and that's why you can say that this is most likely a high pulmonary blood flow patient. Now these two X-rays, again, I'm trying to define high versus low pulmonary blood flow. This X-ray, you can see the right lower low branch. Now remember, they are also mislabeled as LRTI, pneumonia, LRTI, patches. They are all labeled, but see the pattern you have to follow. See, patches will not follow the pattern. See, this vessel goes down and then gives rise to prominent vessel distally. This has to be a vessel. So this is the common site of infiltrations, patches, and right lower lobe branch. This is right lower lobe prominent branch because of high pulmonary blood flow. And you can see the cardiomegaly, where here I don't have a cardiomegaly and I don't have a vessel in distal lung. This is high flow, this is low pulmonary blood flow. Now the question is, which of these patients should receive diuretics? Can we start diuretics in both these cases? Should I start diuretic because a heart disease patient, the most common target diuretics? Should I start diuretics here? Dr. Jay, again, your views about diuretics here.
So diuretics have to be started as per the clinical situation. So if the child is in congestive heart failure, is having signs of that, tachypnea, tachycardia, any sign of hepatomegaly, not gaining weight, then we need to start that. But if the child is relatively well preserved, then we would not like to start diuretics because they have their adverse effects. It can affect their weight gain, it can lead to unnecessary polyuria and trouble the parent. So that has to be dependent on the clinical scenarios at hand.
Okay, but one of these X-rays, which is contraindicated, which X-ray would be contraindicated to start diuretics?
Yes, sir. The second X-ray where we are definitely sure that the pulmonary blood flow is not increased, in this scenario, we should definitely not start diuretics at all.
Yes. So in this patient, I am thinking this is low QP or normal QP. This patient will definitely not benefit from diuretics. You may worsen this patient. So all top physiology patients, all obstructive lesions like AS, PS, they will come into this group and they cannot be given diuretics. Whereas if this patient, if he's in the ICU or in the OPD huffing and puffing with failure symptoms, you can start diuretics before doing the echo here. But this patient, you cannot start diuretics because this patient is a obstructive lesion. Already he is under hypovolemic state in terms of lung flow. So this patient will never receive diuretics by clinical criteria. But this patient, if it's the ICU, suppose the top patient is spell, you should not start diuretics here. But here, if it's in the ICU with chest infection and X-ray is awaited or echo is awaited, then this patient should receive diuretics. Of course, you add heart failure symptoms here. Dr. Shivanand, sir?
Yes, sir.
What do you think, sir, about this starting diuretics in OPD? How comfortable you are when you start diuretics, sir?
No, I usually go clinically. If I get a sign of fluid overload, like a child in respiratory distress, or JVP raised, hepatomegaly, basal craps, so that is a fair enough idea that the child is tipping off. And then if the X-ray is showing flooding of the lungs with a cardiomegaly, then I would go in for a diuretic at OPD level. Only thing in neonatology, I do not prefer using Lasix in a newborn because it is known to keep the PDA open. Especially when you are suspecting a PDA, I prefer not to use Lasix as a diuretic there. Yeah.
Very rightly pointed, sir. Neutral point of view is also really important for us. But most of the times, like what we see is mostly this heart failure patients would come, shunt lesion patients, suppose this is a VSD patient or TAPVC, they would come late into the later part of neutral part, like 3 weeks or 4 weeks of life. Whereas PDA would present earlier in preterm babies, especially. But yes, in preterm babies, we cannot start diuretics without confirming diagnosis. But in older children beyond neonatal life, maybe we can start diuretics before echo also. Now, let's see what are other steps of interpretation of cardiac assessment on X-ray. Because we say cardiomegaly, we should talk about shape also. That means RV versus LV type of effects. I will talk about that. And then vascularity we will discuss in parts. So this is the X-ray where we say how do I assess a cardiomegaly on X-ray. This is especially useful for DNB students, for MD students who are planning to join pediatric cardiology or planning to give an exam. CT ratio is first thing you take for the cardiac part, put a midline, and then maximum measurements on one side and other side. So A plus B is cardiac part, and then maximum diameter of the thorax. So this is C. So that's how you can calculate cardiothoracic ratio. To remember this part, that this cardiac part should not be in same line. It need not to be in same line. It is the maximum diameter on both sides. That is really important when you're talking about cardiothoracic ratio to see cardiomegaly. Normal cardiac ratio would be around 0.3 to 0.55. Then we can try to define cardiac shapes. Cardiac silhouette, cardiac borders can be defined on X-rays. So like if we start with down lower state on the right side, we see IVC. So IVC will come like this here. So this is the IVC RA border. And then I start the RA like this. I start the RA. Then sometimes I get a ascending aorta, then SVC. So that's how you should define an order. Especially right heart border is easy to define. Remember that part at least. Now, on the left side, we start with ventricular border. So this is one ventricle. It may be RV and LV depending on disease. But we are assuming here LV. We'll define how do we say LV or RV borders. And then we have LA appendage. Then we call it pulmonary artery or pulmonary bay, which is basically formed by MP and LPA. So you can see the LPA forming here. And then you have aortic naphtha. So these parameters, try to see in every X-ray, whenever you see an X-ray. This is right pulmonary artery, which I was talking to you earlier. Now, how do I decide whether I have right ventricle or left? Before that, why do I need to know whether I'm dealing with right ventricular or left ventricular morphology? Like some disorders can be defined, can be sub-defined if I say right or left ventricular border. Suppose I have a VSD patient. I know this would have LA and LV dilatation. Similarly, if I have a TOF patient, I know I would have right ventricular forces, right ventricular hypertrophy. So if I can define LV border versus RV border, I can come to the conclusion what disease I am dealing with. Like suppose I have an ASD patient, I have RV borders, RV dilatation. So that can help you in further redefining what the further subdivisions of heart disease. How do we decide RV or LV ventricle? Let's see this example. This is called cardiophrenic angle. Cardiophrenic angle. If this is acute angle, this is RV. Remember the patient of TOF. TOF has RV apex. We all know this. Remember the X-ray of TOF. They have characteristic is this acute cardiophrenic angle. Now remember a patient of VSD, which has LV apex. They have obtuse angle. Sometimes they are undetermined. Sometimes cardiomegaly is huge. You are not able to differentiate. You don't comment on the type of apex. But otherwise, remember a TOF patient X-ray, acute angle. Remember a VSD patient X-ray, obtuse angle, and that is LV. This is RV. But I'm trying to give some hints so that you can remember the RV versus LV apex. Let's see some examples. Now see this a patient of see the acute angle. This is acute cardiophrenic. So this has to be RV apex. Now see this X-ray. How do I decide the cardiophrenic angle? See this cardiophrenic angle. This is obtuse angle. So this is LV X-ray. Now let us read till now what we discussed. Suppose I have a cyanotic heart disease, cyanosis patient, and I have this X-ray. Now I say what is my QP? What is my pulmonary blood flow? We all agree this is low pulmonary blood flow. So I say my child has cyanotic heart disease by pulse oximetry. By X-ray, I say low QP. There is no cardiomegaly, and I have RV apex. Cyanotic heart disease, low pulmonary blood flow, RV type apex. That means diagnosis is something like TOF or DUR. DUR VSDPS basically. So DRV or TOF type of physiology, I am dealing here by this X-ray interpretation and by my pulse oximetry. On this side, if I say my LV apex, I say acyanotic heart disease. Child has saturation normal. What is the pulmonary flow? Right pulmonary artery is prominent. Distal 1/3 is being used. So I say it's high QP. So I know this is a shunt lesion. Now in shunt lesion, I have ASD, VSD, PDA, APW, AP window. Among these, I have to choose. Now I should know which disease have LV dilatation. If I say VSD, PD and AP window, I know this. VSD, PD and AP window have LV dilatation. Only ASD would have RV apex. So this has to be one of these lesions. Large VSD, large PDA, large AP window. And large shunt because QP is slightly high. Pulmonary flow is high, which is possible only with significant shunts. But as we read in the books, it has to be minimum 1.5:1 shunt. So this is a most likely a ACSD with VSD, PD and AP window that is called post-tricuspid shunt. And this is most likely a TOF physiology patient where I am suspecting TOF or DOR. That's how I can define. Now I know if child is huffing and puffing, I will start diuretic here. But if child is even in distress, child has come with distress, I will not start diuretic here. I am dealing with the cyanotic heart disease spell patient. Child is in distress because of spell. So I would give volume here. I will give fluid volume here. After seeing this X-ray, I'm sure that this child would not need diuretics and I should give volume even if child is in respiratory distress, because respiratory distress may be because of spell. So some more examples of pulmonary plethora. This is a very important part to learn in today's class. Because pulse oximetry we all know, but understanding the pulmonary blood flow patterns is highly, highly important. So you can see again, cardiomegaly, uniformly enlarged vessels, white lungs, and this shadow, don't treat this as LRTI. See, this is a typical shadow of right pulmonary artery prominence, and this gives rise to branches. Try to see the branches as you see on a CT scan. Try to see these branches, and you will be delighted to see that if you start diode in these patients, these shadows will go off. Then end on view showing end on vessels. This is difficult to understand, but accompanying bronchus and you see end on vessels. But they are mostly with white lung. They are situation of the high pulmonary blood flow. This is another criteria for high pulmonary blood flow. Again, this we discussed. It has to pass beyond 2/3 and prominent middle 1/3 part. So white lungs, cardiomegaly, prominent right pleural branch. You are dealing with the high pulmonary blood flow. Now, if you say high QP, I say this is high QP for sure. I need to know ACHD or CCHD. If I say CCHD, I know as we have discussed in the list, this has to be some TAPVC, TJ with VSD, DORV with VSD, but no PS here, no PS. Cyanotic without PS. ACHD shunts, large shunt. And if I define the apex, ventricular apex, I can say whether it's a VSD or PD or ASD. Similarly here, I can say what type of disease I am dealing. So till now, I have decided by NADA's criteria, by pulse oximetry, by clinical and chest X assessment of pulmonary blood flow, RV or LV dominance, we have decided by chest X-ray again. After this, let's go to some case scenarios. Now, this is the patient, 6 months old, saturation of 95%, having fever, cough, and cold, and having tachypnea. Patient has come to my ICU, admitted in the ICU with tachypnea. There is some distress. Murmur is there. I'm not able to show what type of murmur is there because child is distressed. There are no cracks. What is the possible diagnosis here? Dr. Jay? Dr. Jay?
Yes, sir. So with the clinical setting that is given, a 6-month-old child has come with symptoms of cough, cold, and tachypnea. So tachypnea is one indication that the work of breathing is increased. So we start clinically. This is systolic murmur present, which indicates that probably we are dealing with a cardiac condition than just a respiratory condition. Then the child is irritable, but there are no crepes. That is one thing. But in infancy, crepes may not be there even if the child is in heart failure. So when we do this X-ray, what we find is that there is cardiomegaly definitely. And if you look at the lung field, the pulmonary blood flow is also increased. So we have to think in lines of that we are dealing with a condition acyanotic or cyanotic where the pulmonary blood flow is increased. Because the saturation is 95%, and if it is at room air, then we consider it as an acyanotic heart disease with increased pulmonary blood flow and most likely a post-tricuspid shunt, which has come to us in heart failure. So we will work along those lines and
Type of
start
apex?
diuretics and
Do
things
you
like
want to comment on type of apex, Dr. Jay? Type of
that. Yeah,
apex?
in this, you can see the apex more, it looks like an obtuse kind of a apex. So it's an LV type of an apex.
Yes.
So probably post-tricuspid shunts only will lead to that, like VSD, PDA, AP window.
Yes. So post tricuspid means the shunts for the students beyond tricuspid wall, we have VSD, PDA, and AP window. So we are not talking about pre-tricuspid, which are ASD or PAPVC. ASD or partial venous return we are not talking about. We are talking about VSD, PDA, APW because LV is dilated. Post tricuspid would have LV dilatation, and pre-tricuspid ASD or PAPVC they would have RV dilatation, and also they will not be symptomatic at this age. Mostly post-tricuspid will present earlier at 6 months of age. Pre-tricuspid ASD will present later beyond 2 or 3 years or maybe more than that. So based on some clinical pattern, without much going into the murmur details, I have come to the conclusion that this patient has a high flow, most likely post-tricuspid shunt. All these groups, if they're coming, I will start a diuretic in the ICU actually to reduce the pulmonary congestion. Now, this is another patient, 2-year-old, early tiredness, 2-year-old, gets tired, gets cyanotic with breath holding, loud, harsh murmur. Murmur is in the right infraclavicular space. And let's read the X-ray now. First thing here is, so child is getting cyanotic and is loud murmur. But let's read the X-ray first. Do we have cardiomegaly? No. So there is no cardiomegaly. CT ratio appears normal. What type of apex we're talking about? Obtuse angle. So we're talking about LV type of apex. Now, QP not passing beyond 1/3. Some vessel is seen, but not passing beyond 1/3. But I would not say it's a high QP, but it may be normal QP or low QP. But I would not say it's white lungs. Now, no cardiac enlargement, LV type X. I have not seen the pulse oximetry here. I need to see the saturations. So if SpO2 is important part here to describe. If I say SpO2 95%, this becomes acyanotic heart disease. Loud, harsh murmur, normal QP. It has to be obstructive lesion, one case. Second would be ACHD. I told you small to moderate shunt, not large shunt. Either it's obstructive lesion or small shunts. Now, location of murmur, right infraclavicular space, that is the diagnostic clinch. You know aortic valve is here. So we are dealing with aortic stenosis and not PS. The PS murmur would be on this side. It has to be AS and LV apex. LV apex will go with my diagnosis of aortic stenosis. So remember again, acute angle versus obtuse angle and location of murmur. That is the diagnosis. QP is not very high here. Some people may say, I see prominent vessels. That's why if the murmur is not there in this picture, murmur in the left third, fourth intercostal space, I may be dealing with VSD, which is moderate shunt or small shunt. So they can have loud murmur, but the location of murmur will be different. VSD murmur will not be seen right side, it has to be in the left parasonal area. One more X-ray. This patient again, saturation 95%. And if I say continuous murmur, there are few lesions which have continuous murmur, not all lesions. Then let's see the type of apex. It is obtuse angle. I see prominent pulmonary artery, QP, possibly normal, but continuous murmur, LV apex, and prominent right lower branch. So what lesion I am dealing with? Most likely a PDA. Most likely a PDA if I have a continuous murmur, prominent pulmonary artery, LV apex, because VSD will not have continuous murmur, AP window will not have continuous murmur, PDA would have a continuous murmur which is not large. So it is a small to moderate side of shunts, which is giving continuous murmur, saturation normal, and LV type of left ventricle type of. Dr. Jay, please keep seeing the question answer box also. And you can interrupt if some question is there relevant to the present slide.
Sure, sir, sure.
Okay. Now, again, we have a symptomatic child who is cyanotic, murmur in left space, saturation 80%. So let's see. Do we have a heart disease? Yes, because murmur is there and cyanosis is there. The major criteria is filling. So it has to be a heart disease, CHD. Now, whether I'm dealing with cyanotic, yes, saturation are low, I'm dealing with cyanotic heart disease. Now I have to see the pulmonary flow. I want to see QP, pulmonary flow. It is not crossing the 1/3. No cardiomegaly also. So I'm dealing with low pulmonary blood flow. Apex type, acute angle. So RV type of apex. So I'm dealing with cyanotic congenital heart disease, low pulmonary blood flow, RV type of apex. So I come to the TOF physiology spectrum. One is TOF, one is DORV. Can it be tricuspid atresia also? What about tricuspid atresia? Dr. Jay, do you think this can be labeled as tricuspid atresia also based on these X-rays?
In tricuspid atresia, the apex is left at the LV type of an apex, and this X-ray clearly shows a RV type of an apex. So yes, tricuspid atresia would be unlikely in this case.
Yes, because tricuspid atresia don't have RV, they have small RV. They have mainly direct LV prominence. Tricuspid atresia means there is no flow going from RA to RV, and RV is small. If RV is small, that will not be apex forming. And if we say apex forming, RV is apex forming, we have almost ruled out tricuspid atresia, unlikely to have a tricuspid atresia type of spectrum in this group. So I'm dealing with cyanotic heart disease, low flow, but if this child is coming into my emergency spell, I will start beta blockers. I know this is TOF physiology, and I'm not starting diuretics. That is the thing which you should be able to differentiate after this X-ray. So I will start beta blockers here and no diuretics. That is very clear after my this slide that I'm not dealing with high flow situation. My child is not symptomatic with failure. My X-ray not suggestive of heart failure. And I'm talking about beta blockers here. These are some classical X-rays. I have put one or two classical X-rays just to tell you that everything will not fit into my spectrum by X-ray. That's why sensitivity and specificity of X-rays is not that high as echo, where we all know this. This child is mildly cyanotic, tachypneic, SpO2 of 88%. These are called classical X-rays, but if you see these X-rays, you can say this is a patch. But see, if child has cyanotic heart disease, mild cyanosis, mild tachypnea, and such a big patch, you may be dealing with some uncommon cardiac disorders. Similarly here, prominent pulmonary artery bulbs. Whenever you see such big shadows in the pulmonary artery area, they're very uniform. See, they're uniform vessels, unlikely to be a patch or infiltration. We talk about some uncommon anomalies. One of them is TOF with APV. absent pulmonary wall. The classical X-ray, keep this in mind that this may come into your practice. TOF with absent pulmonary wall. They have hugely dilated pulmonary arteries and they present with mild cyanosis, mild tachypnea. And these patients sometimes need diuretics. So they have PS and PR physiology with absent pulmonary wall like this. These patients should be referred immediately to the cardiac units for specific management. This is a 4-month-old child, 4-month-old child, no episode of LRTA and cyanotic. Cyanotic saturation 75%. So I have a CCHD and no murmur. CCHD, no cardiomegaly, no cardiomegaly, no cardiac enlargement. QP, pulmonary flow, not crossing 1/3. Some vessels in the middle 1/3 only. So I'm talking about low pulmonary blood flow. So again, cyanotic heart disease, low QP. And now let's see the apex. What type of apex this is? LV. This is LV, not RV. CCHD, cyanotic heart disease, low pulmonary blood flow, and LV type of apex. Rare disorder, tricuspid atresia. Compared to TOF, this is tricuspid atresia, some VSD or PS. If there is no murmur, maybe pulmonary atresia, but sometimes severe PS may not have murmur, tight PS. So either tricuspid atresia, VSD, PS or pulmonary atresia group of the spectrum, where we are seeing oligemic lung feeds and LV type. This is just to tell you, you can start beta blocker here also. Cyanotic heart disease, no flow to be defined. And if you're not able to identify LV or RV apex, even then you can start beta blockers if this is in your emergency with SPECT. Every X-ray need not to be boot shaped because every child will not have TOF. 6 months old, tachypnea, SpO2 high or low, means SpO2 on the higher side, but saturation low, CCHD. Now see the shadows, pulmonary flow. I don't know, maybe QP, but it's not low, maybe borderline high or normal. Normal QP, maybe. And now see the type of apex. RA, here, cardiomegaly is there. Cardiomegaly is definitely there. Type of apex, again, acute angle, so RV apex. So we are dealing with cyanotic heart disease, QP not low, cardiac enlargement, RV apex. And then we see this shadow in the upper body. Classical X-rays, figure of 8, TAPVC. So TAPVC sometimes may not have excessive high flow in early age. So some high flow situations may be balanced out. That's why this patient, if he's stable, I would wait for the echo. Cyanotic heart patients, normally we try to have an echo earlier, but if it's not possible, I would, if child is symptomatic in the ICU, I would give diuretics here, otherwise not. Now, trying to say, not all figure of 8 features would have TAPs. It's a neonate. They all three are, this is 4-month-old child, this is 2-month-old child, this is 1-month-old child, all sent to us for suspecting cardiomegaly shadows in the neonatal life. So see this X-ray, start with this X-ray. I have these borders. I think again, figure of 8, RV apex, QP is high definitely. If here, compared to this X-ray, see this X-ray, again figure of 8, RV apex, but QP I'm not sure here. But again, the APVC, this one also looks like cardiomegaly. Most important part to differentiate would be thymus. How do I differentiate thymus from figure of 8? And this type of shadows are common point for referral to us. One of them is if they are typical like thymus, this is all thymus shadows actually. But typical thymus is easy to pick up. Cell sign is easy to pick up. But here, do the pulse oximeter. Do the pulse oximeter. If SpO2 is 95, 97, I've ruled out. Most of the time, it's not TAPs. So I can follow this patient. There's no emergency to start therapy here. But if stats are 88, 90, I'm talking about possibly a TAPVC. Again, remember, in a neonate, figure of 8 will not be seen. Figure of 8 will take some time to show on X-ray. So 4 months to 6 months is the time when you talk about figure of 8 X-rays. Few X-rays which are difficult to interpret in terms of bags, in terms of pulmonary blood flow. There you have to go more clinical. This patient has acyanotic heart disease. We don't have the further understanding of murmur. X-rays were sent to us. The typical X-rays show box-shaped heart, massive cardiomegalies. DD is very simple, X-teen or pericardial effusion. So go with the clinical settings in such scenarios where I'm not able to differentiate type of apex, but you have gross cardiomegaly is one of the X-rays where you don't have undifferentiated apex. So you can't differentiate whether I'm dealing with RV or LV apex. Here also, RV or LV apex cannot be defined because of huge cardiomegaly. But when you have huge cardiomegaly, DDs are mainly F-seen, pericardial effusions, or some other rare group of disorders. This is a 14-year-old child incidentally diagnosed hypertension during an episode of febrile illness. What examination you want to do here when you see a newborn older child with hypertension? Most common thing I want to say is lower limb pulses. I want to rule out coarctation, cardiac illness, and then renal concern. For cardiac, upper and lower limb BP should be seen, upper and lower limb pulses will be seen, and then you should try to rule out coarctation of aorta. Now, incident in the bigger children, classical X-rays are seen, figure of 3. You can see the figure of 3 here. This is the point. You can see this part of coarctation and then post-dilation. These are our real patients. They are not from the picture. They are not from the net. They are our real patients. All these X-rays are our real patients. This patient came to us with this X-ray. And you can see hypertension with this X-ray, diagnosis only one, coarctation of aorta. Dilated ascending aorta, notch, a site of coarct, called figure of 3 sign. AAP recommends all children who are coming to your OPD beyond 3 years, BP should be taken. So NADA's criteria says if you have normal BP, you're talking about a possible heart disease. So BP on all cases beyond 3 years of age. The pickup coarctation. Look beyond heart. Of course, 20-year-old child, murmur, respiratory distress. This child came to one of my peripheral OPDs with 20-year-old child, respiratory distress, murmur, penicillin murmur was there. Respiratory distress was definitely there. But echo shows small VSD. Now, distress with small VSD not matching. Again, X-ray was done to find out what is happening. And the answer is clear. There are eventration causing symptoms. Diaphragmatic hernia. Now, we have spoken a lot in length about X-ray utility, but understand X-ray has accuracies only 78%. This was retrospective review of interesting study and chest X-ray from 281 patients by 5 pediatric radiologists from 3 institutes. An average accuracy to distinguish normal from CSD patient was 80% only. So that is the point. X-ray cannot be the diagnostic criteria alone. Add clinical information into this, add saturation, add murmur, and you'll come to some conclusion. Now let's go to the ECG in structural heart disease. Ajay, Dr. Ajay?
Yeah, yes, sir, yes.
Please talk about some ECG. When do you do ECG? When do you think really important that you have a ECG? Please.
Yeah. So when we think about ECG in patients with heart disease, ECG is more important in case of patients who are presenting with top physiology, for example, when we are wanting to classify which lesion we have. Otherwise, when we are dealing with a patient with heart disease, suppose have presented to us with heart failure, and we go for an ECG, and if we find that the left-sided voltage complexes are large, then we suspect that we are dealing with a post tricuspid shunt. While if we find that the ECG is normal, and is unable to explain the condition that we are dealing with, the clinical condition, then we can fairly rule out the heart disease part. But when we have a particular scenario, for example, if the patient is having cyanosis and we are doing an ECG, then as we were doing in case of X-ray, dividing it into a RV type of an apex or LV type of an apex, ECG can also help us in detecting the same. The right-sided leads, which we call in the chest leads like V1, V2, V3, they represent the RV, you can say the right ventricle. While if we look at the leads V4, V5, V6, which are left-sided leads, if the complexes are more prominent in that lead, then they are likely to suggest an LV type of a, you can say predominance.
Yes.
Something
So,
like
so Dr. Jay, most of the times when we talk about ECG, any our practice, as you know, we talk about ECG mostly when we're talking about arrhythmias. Most common indication we do is for the arrhythmias. And then in some cases we try to take the help of ECG to find out a heart lesion, like you said, Al-Kappa. So in our practice, arrhythmias, Al-Kappa are two common lesions where now we always do an ECG. That yes, this CHD patient I want to pick up and arrhythmias and Al-Kappa. Beyond this, if you've done X-ray, do you think most of the times do you need an ECG to define a disease like I said, arrhythmias and Al-Kappa? So let's go to that part now. Once we have decided cyanotic heart disease, shunt or obstructive lesion, these three things have been defined by X-ray very easily actually. Then let's see how do we decide more useful ECGs. Like few reasons where X-ray is more useful is shunt. We all know shunts are best picked up by X-rays. ECG more useful when, as Dr. Jay was saying, trying to see the type of apex, RV type of apex or LV type apex, where I'm not sure I may be useful is ECG, where you want to see strain pattern also. So when you're suspecting an obstructive lesion like AS, PS, and coact, you're talking about ECG, and PS would have RVH, AS would have LVH. So left side obstructive lesion will have LVH, right side obstructive lesion would have RVH. Similarly, in cyanotic lesions, to differentiate types of TOF physiology, TOF and tricuspid atresia, when you're not sure on X-rays, ECG might be a useful clue. Like let's learn this by an example of a case. If you have a 2-month-old child, 2-month-old child, sudden onset of cyanosis with crying, hypernia followed by fluishness, child sleepy after this episode. So I'm possibly we're talking about a spell. Because on cyanosis with crying, hypernia and child becoming sleepy after episode is spell phenomena most likely. On examination, we find 65% saturations and liver not palpable. So possibly cyanotic heart disease here, cyanotic congenital heart disease. So cyanotic congenital heart disease with low pulmonary blood flow. Because why I'm saying low pulmonary blood flow? Because they don't have a chest infection, they don't have a liver. So I'm talking about low pulmonary blood flow group. Now my differential would be TOF with or without pulmonary atresia, some variants of DORV, tricuspid atresia, or single ventricle variants with PS. So I'm dealing with one of these disorders. In such situation, beyond X-ray, let's see the X-ray first. This is X-ray of TOF. You can see the RV apex, low QP. This is X-ray of tricuspid atresia, where you see the obtuse apex and low QP. So this is LV apex, this is RV apex. Some I've seen anomaly with gross cardiac value. Now, if you go to ECG, in TOF, I suspect it has to be RVH. Sorry, RVH should be there in TOF patients. How do I decide right axis and right axis and RVH? Basically, right axis and RVH. So axis one is negative, AVF is positive. I'm talking about RAD, right axis deviation. When you have one negative, AVF positive, easy to map this right axis deviation. And in right-sided leads, as Dr. Jia was telling, V1 to V3, you have right ventricular forces. And so right ventricular hypertrophy here, because prominent R waves in right-side leads and prominent S waves in left-sided leads, suggestive of RVH. So right ventricular forces, right axis deviation, I'm dealing with top. Let's see the ECG of tricuspid tracer. Axis, one is positive, AVF is negative. They're away from each other, so this is left axis deviation. One positive, AVF negative. This is very important for all the DNB students, especially that cyanotic heart disease with low flow and left axis deviation. Left axis, there is only one diagnosis, tricuspid atresia or DILB. But mostly for exam, tricuspid atresia. And then you have in the leads, see the only S wave in V1, V2, V3. So this is pattern of LVH. So we have cyanotic heart disease, low flow with LV forces on X-ray and ECG. This has to be tricuspid atresia. So in ECG of tricuspid atresia classical, when you see left axis deviation with left ventricular forces and cyanosis, this is tricuspid atresia, beyond doubts. So summarizing, I will try to have NADAS criteria first, then I come to cyanotic or acyanotic group. In acyanotic group, I decide high flow or low flow. If I have high flow, I'm talking about shunts. If I'm talking about normal flow, I'm talking about obstructive lesions. If I have cyanotic heart disease, top physiology spectrum in low flow, high flow, TAPVC truncus without PS single ventricle, DORV, TJ with VSD would have a high flow X-ray. And I can decide on clinical parameters on X-ray high flow. So these patients can be given diuretics. These patients should not be given diuretics. This should not never receive diuretics. And these patients may be given diuretics based on clinical symptoms. Thank you for the patient listening. I would request chairpersons to have their views and some questions. We can invite question answer, sir, or we can invite the chairperson's comments, sir.
We do not have any questions in the chat box, I guess. I think everyone who has any queries can be put in the chat box. Dr. Neeraj is ready to the queries.
I see one question. Which pulse oximeter is to be used in neonate in OPDN methods? Which pulse oximeter is to be used? I would not have right answer for this, but Massimo is supposed to be best. That way I have heard that Massimo is best for everything. But different parameters are there, different multi-parameters are there. In older children, even the small pulse oximeters, which are available in 2000 to 10,000 range, are sufficient for older children. For newborns, I would suggest Massimo. I would invite the opinion from the chairpersons to also about this pulse oximeter, sir.
Well, I have been using Nelcor 595959 in my OPD since last 15 years. It was available as a refurbished one initially, though now new ones are also available. I did not have any problems with it. In fact, the probe that was used was previously we used to have a plastic one. Now we are using is a disposable one. No issues with that.
Okay, sir.
Well, I would prefer pulse ox, especially in a neonatology if you are dealing. I would prefer a pulse ox which gives pulsatility index also. So you know how the perfusion, you can gauge a little bit more data about peripheral perfusion. So it is a ratio of pulsatile flow to non-pulsatile flow. So if the ratio goes below 1.2, you know that perfusion also of the patient is poor, especially in coarctation of aorta type of situation. So pulse ox along with plethysmograph with pulsatility index will be better than simple pulse ox.
In the NICU, sir. We are talking about basically for the NICU.
Especially in an NICU setup.
Yes. Then we have some question like how to differentiate systolic versus diastolic murmur in neonates. You're right. Actually, in neonates, that you can't differentiate systolic diastolic unless child is very quiet, heart rate is high. You are right. So that's why in neonates mostly we don't talk about systolic or diastolic murmur. We talk about murmur or no murmur in newborns. Sometimes if you can differentiate continuous murmur, that is easy. So you can differentiate continuous murmur from systolic murmur, but systolic or diastolic is difficult to differentiate in units. We can say murmur or not murmur in units or continuous murmur in that case. Then next question is, can right pulmonary artery shadows normally present in older children, which can be confused with highlight shadows? Mostly in older children, the size of right pulmonary artery has to be measured. So if a child is beyond 10 to 12 years of age, RPA is normally seen, but it has to be more than 16 mm. The criteria is 16 mm. So to call it abnormal RPA in older children. In smaller children and younger children, as you see, they should not be seen. I think that should answer your query for the right pulmonary artery. Then I have a question. Sir, one more question we have, sir. Sir, you can, Dr. Shivanand, sir, can you see the questions also?
No,
Are you-
I can't see. I can't see the question.
I don't know. Okay, I will see this, sir. If increased pulmonary blood flow pathology diagnosed on routine checkup, he is saying if increased pulmonary blood flow pathology diagnosed on routine checkup, not in failure, could diuretic be started, sir? See, if child is not symptomatic and you can get a echo in 1 or 2 days, then there is no hurry to start diuretics. You are talking about a situation where patient admitted with you, where you are, if child is admitted with you with symptoms of heart failure or tachypnea, then you should start diuretics. If child is stable, there is no urgency to start diuretics in the OPD because you can confirm diagnosis nowadays. But if you think that the confirmed diagnosis would take 3 months, 4 months, then yes, you can start diuretics. So no open questions for now. We can have more question answers from chairperson, from moderators, from other panelists. That is possible. Any comments? Any comments are also invited from panelists.
I would like to make one comment, sir. Your TAPVC, which X-rays were shown,
Yes.
figure of 8, was a black lung TAPVC. So only one point for a neonatologist is very important is TAPVC could be with white lung also, and it can mimic total RDS like hyaline membrane disease. And usually a person get fooled and start treating it as a hyaline membrane disease, and you get stuck on the ventilator and surfactants doesn't work. So one has to remember that if you get a white lung TAPVC, it is an obstructed TAPVC, it is an emergency, and you cannot use vasodilators here. If you use a vasodilator, patient deteriorates in this white lung TAPVC. So one should not have a notion that always the TAPVC will be black lung TAPVC. Black lung is ideal, it is non-obstructed, but the white lung is more dangerous. So if you get a white lung TAPVC, it is a cardiac emergency.
Yes, child will not see the next day. Yes, child will not see the next day if we are
Yes.
wrong in the observed TAPVC. Yes, sir. Thank you, sir. Thank you. If there are no questions, nothing more. Dr. Mridul is there. Dr. Mridul, you are there. I see you in the panelist today. Are you here, Dr. Mridul? Dr. Mridul, are you here?
Yeah, I'm here. Yeah.
Any comments from you, Dr. Mridul, for today's session? Anything you want to add, or what you see in your practice? And
I
please,
think you have explained everything in very great
but please
detail.
you show your face also to the audience.
Yeah, I don't know.
No, keep
It's
the
good.
video on. You are the program director of this course. If it's okay for you, otherwise, yeah. So you will keep seeing Dr. Mridul also in the future programs. He is with us for last 15 years, and he is a senior consultant in our department of pediatric cardiology. We all do together work. Actually, we do all the intervention, neonatal pediatric cardiology, pediatric cardiac interventions. We all do together. So Dr. Mridul you will see in arrhythmias, he has special interest in arrhythmias and fetal echo. He does a lot of fetal arrhythmias, fetal echo interventions. That is the plan in future for us. So if nothing is there, we can stop the session, sir, with your permission, with the chairperson's permission.
Yes, sir. Yeah.
Okay. Okay, sir. Then we stop the meeting and we'll see you next time, sir. Thank you for joining all attendees, all panelists. Thank you all. Thank you, IP Delhi again. And we can close the meeting now.
Thank you. Thank you very much.
Thank you.